Good morning. Thanks everyone for coming. It's great to see you here. So today I have the pleasure of introducing an old friend and certainly very experienced in his field. Matthew Quinn has held positions at the National Institute for Standards and Technology, or NIST, the Agency for Healthcare Research and Quality, AHRQ, GE Healthcare, Intel, the Federal Communication Commission, and now the Health Resources and Services Administration, or HRSA, at Health and Human Services, HHS. I met Matt while he was the managing director of Intel's East Coast healthcare practice. And I'm going to ask Matt a series of questions. Hopefully, Matt, you can opine
and answers too.
Enlighten us. So to start off with, Matt, what is HRSA and what's your role there, especially as it relates to big data, machine learning, and analytics?
Certainly. So HRSA, raise your hand if you know what a HRSA is.
Oh, wow.
Okay, so there's a few folks here. So HRSA is part of the Department of Health and Human Services. I'm the senior advisor for health technology there, which is a new role. HRSA has approximately 90 different programs in areas like in federally qualified health centers, workforce, maternal and child health, HIV and AIDS, and the Ryan White Fund comes through HRSA, the Federal Office of Rural Health Policy, lots and lots of different things. I discover new programs at HRSA every day, and my job as senior advisor is to look at those programs, work with those programs, and think about how they can use technology to support their goals. I'm also the point person for HRSA touching other agencies or working with both the public and private sector on the use of technology. And I learn new things every day that I bring back to HRSA and try to make happen. Something that is different for me as someone who's worked in regulatory agency, who's worked in research agencies, and then at NIST, which is working with industry, is that HRSA is very much an operational agency. Those 90 programs are running and doing a great job, but often not thinking about how they interact with other programs in HRSA and also the outside of the world. So I have to be very mindful of that role and not disrupting what they're doing, but thinking about how they work and helping them work better.
Super. So HRSA is not necessarily known for big data. What's your background as it pertains to analytics, big data?
So I've been thinking about the role of data in improving healthcare, measuring healthcare, and as it relates to new care models for a long time. Sean mentioned some of my background. Probably the role that I have now is trying to think about what's possible. So if you don't measure it, you can't improve it. And today what that means is very different than what it meant a long time ago, when we thought about measuring things maybe once a year and moving forward. At GE Healthcare, I was the product manager of Six Sigma for Healthcare, Clinical Outcomes Performance Improvement. And what that meant was both working with healthcare organizations to implement and institute data analytic tools, but also the internal capacity to use that data for improvement activities. And I remember back in the province of Ontario had a program where the Hospital Association would literally publish the quality scores for the hospitals in the newspapers once a year. And the hospitals wouldn't know, the CEOs of the hospital wouldn't know what was coming out. So it was all this big surprise and everybody was kind of scared about this. What we worked with them on was knowing ahead of time, but also having the improvement capability so that they could get that score that was published in the paper that was actually a year prior before. Let's think forward and think about those same hospitals as they're now being paid for performance and value-based care. Trying to, not in Canada, but here, think in the same situation where they really need to know these things and implement them and make sure that the individual clinicians and administrators and everybody knows in real time what's going on and to intervene before it's in the newspaper.
Thank you. So you talked a little bit just now about your background as it's interwoven with healthcare. If you had three things to say to your peers at HHS or MilHealth or research organizations inside of the federal sector about analytics and big data, what would those things be?
The first is that big data and analytics aren't a thing. They're a journey. And getting there really takes time. And it takes resources, and not just technical resources. It requires some wherewithal, and it requires staff, data scientists, and others. In preparation for this, I ran into a couple of my colleagues. I work in a part of HRSA called the Office of Planning, Analysis, and Evaluation, OPAE. And we're the folks in HRSA looking across the different bureaus and offices. And one of my colleagues recently moved from OPAE into the Maternal and Child Health Bureau, and she was back up. And I said, "So what are you doing back up here?" And she said, "Well, now that I know that there's data from across HRSA up here, I can use it and leverage it for maternal and child health." And I said, "Are you a data scientist?" And she said, "Well, technically I'm an analyst, some weird code 03, but in government speak. But yeah, I'm a data scientist." And that's the sort of capacity that, whether it's HRSA or some other federal agency needs. And these people are gonna, part of the recruiting process, and maybe recruiting for a data scientist, but finding those skills or developing those skills internally, as well as trying out new technologies and new things to think about solving problems. That's one. The second, and this is a common reason for failed initiatives in this area, is not having a business sponsor or a real world problem to solve. And that really grounds it in reality, and it isn't just a technology exercise. It's like, so what do you need to do, and what are the right technology tools for the job from an analytic perspective? How are you going to get the data? What are the sources of the data? How often do you need it updated? Really, you just want it once a year to publish in the newspaper? and so thinking about a real world problem to solve that's urgent, and there are three that are big priorities for Secretary Price. One is focused on the opioid epidemic. The second is around mental illness, and a third around childhood health and obesity. And projects in those areas are quite urgent, and lots of other ones around chronic care management and saving money, lots of these things, but it has to have a real owner. And then the third, I would say, revolves around eating your own dog food. It was much easier at FCC for us as a regulatory agency to, or anybody in the government to say, before we put out a rule or before we do this, we should probably be a shining example of doing that, right? And it reminds me that eating your own dog food reminds me of being a parent. I have twin 7-year-old boys, and one of them has this new trick that when I say, "Hey Taylor, no more, put away your screens," and whatever I say, he says, "No, you put away the screens." So imagine that every day. So imagine that, the federal government says, "Hey, you need to do XYZ. No, you need to do XYZ. So it's the Taylor rule. And, in terms of eating your own dog food, it doesn't need to be terrible like that. My colleague at Intel, Alice Borelli, used to say, it's not eating your own dog food, Matt, it's drinking your own champagne. Whatever.
There you
but
go. That's better.
It's great. Those are the three things.
Thank you. I told Matt I was going to go off script. So I'm going to go off script. This isn't on here. So I was backstage earlier listening to Matt talk to another healthcare expert, and you all were talking about devices. And that's one of the things at Cloudera that's been amazing. Can you just sort of wax philosophic about IoT and these? I didn't know these devices had passwords or related to the FCC. What is all that about?
Yeah, so it's not possible to say the Internet of Things without either using jazz hands or big eyes or a combination of those two or moving them. So I challenge anyone to say that. And that really reflects sort of the exciting future nature of what we call the Internet of Things, which is both the Internet of, which is the connecting stuff, and also the things. From a federal perspective, there are lots and lots of issues here, not the least of which is how are you going to manage this stream of data? If you talk to physicians or others, they say, oh my God, the stream of data is going to be unbelievable and yada, 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 right? But the issue is how do you separate the signals from the noise and make something really useful for that? So that's another big challenge. So folks at NIH are working on big data to knowledge and other applications. Another set, and this relates to my colleague backstage, is thinking about interoperability of all of these devices. Another layer is the cybersecurity of them. It's very different. This intersects a lot with the smart home. And there are NIST initiatives and other initiatives around making these things real, but then thinking about how do you safeguard them, how do you educate consumers and others to change passwords, not take the default password as it comes off, use the network in an efficient way so that it's not interfering with other things. So getting from there to here, again, I think there are great opportunities for the government to demonstrate these things. Second, the eating your own dog food. Second, there are some great opportunities to use these technologies in what we call the Internet of Things to solve real world problems, not the least of which is perhaps around the opioid epidemic. And last but not least, thinking about this as not, you have the Internet of Things or you don't. It's a journey to get there. I was going to give you another example of how that. At HRSA, we have the Office for Advancing Telehealth. And raise your hand if you know exactly what telehealth is and is not. Yeah, that guy does. The challenge is that this is a whole new set of technologies and thinking about it holistically. HRSA is about a $10.5 billion agency. It touches over 24 million people in this country. And, but about 90% of our budget or more passes through us in the form of grants and contracts and other things to those individuals and communities. Over 3,000 different types of organizations, including federally qualified health centers and rural health centers and communities and clinics and all of this receive this. So our role at HRSA isn't just running contracts and doing things ourselves. We have a whole set of technical assistance resources. One of them, we run 14 different technical assistance centers for advancing telehealth, 2 national ones and 12 regional ones. So we, in many ways, need to think through what they need to know as well as learn from them about what's going on in the field in areas like this. We've seen some amazing progress. I'm going to spend tomorrow up in Baltimore at a clinic who is going to show us how they're using telehealth technologies, including some of these smart devices, to care for patients remotely, to address some of the workforce shortcomings. And I'm sure we're going to also hear a whole bunch of things about how they'd like to do more, but this is in the way, and we're not quite sure how to do this, or maybe they're just doing it. And we've got to know that too. So this is one of my favorite topics because there are just so many layers to it, and getting ahead of it and trying to anticipate it is, I know that feds on all levels are getting together on this around specific problems and trying to figure it out.
Thank you. And good job going off script there.
Oh.
So, I was talking a couple of weeks ago to Cloudera's cyber expert, and he threw out something which I sort of took me aback and made me smile. He said, well, healthcare is 10 years behind everyone else in cyber. And I had no argument with that. Is the U.S. federal government behind, in parallel with, or ahead of commercial industry when it comes to analytics in healthcare, do you think?
If I think of who's the furthest ahead in terms of analytic capability, it's certainly the private sector. There's some wonderful examples of really innovative things, and because there's a clear business case for it. You know, some health plans, Kaiser Permanente, for example, has been doing this for a long time. But again, it's been facilitated in many ways many times by federal investment, or in the federal government has to think about it in different ways. So in terms of the maturation of analytic capabilities at your everyday doctor or community hospital or health system, that's been spurred on by the federal government requiring, or providing incentives, I should say, for meaningful use of electronic health records, for encouraging health information exchange, at a high level for paying for care differently in terms of value-based care that requires folks, number one, to work together, but two, to manage care. So what the federal government does in terms of incentives for the need to, a business reason to have analytic capability is really important there. The other side of this, I would say, and I'll put my NIST hat on, which smells like engineers, is in working in conjunction with the private sector to get to standards that facilitate this. So this is also part of the Meaningful Use program, but without standards, these things are a lot harder to accomplish, whether those are cyber standards or the cyber NCCOE or data standards for health information exchange. This is a key role of it. And again, to go back to my HRSA example, something that this makes me excited as somebody who works for HRSA, and I intentionally work here because this is such an exciting population where, HRSA supports the safety net. And the safety net, not only do HRSA grantees and HRSA health centers, almost 100% of those health centers, federally qualified health centers, serving the safety net, have electronic health records. About 90% of them are in the Meaningful Use program, and about 70% of them are patient-centered medical homes. So in a lot of ways, because of HRSA support and because of HRSA's programs that we've put in place for technical assistance, these folks are on the cutting edge of healthcare. And they are early adopters of telehealth technologies just because staffing shortages require it. And the ability of their patients to travel requires it. The ECHO model for telehealth, for example, was promulgated because people were struggling to get hepatitis C treatment to drive all the way across New Mexico to Albuquerque. And they said, well, what if we establish secure linkage between the doctors in the far places and the near places and share that information? And you can imagine building on top of that, measuring vital signs and sending them here, or even continuous real-time remote patient monitoring. Then you're getting to big data, and that's the sort of acceleration that we're trying to provide or facilitate for not just healthcare, but for the safety net, those serving those with low income and other challenges in often rural places as well. So.
Got it. When you were running Intel's East Coast Healthcare group, what were you surprised by in big data and analytics?
It was amazing, the progress that had been made in just a short amount of time. And I spoke about my experience at GE, where we moved my data analytic product from something that many of you are too young to remember called FoxPro to
They remember it.
to Oracle to provide some scalability. It was and from a client server application to a web-based app. And I also made a stop at a company called Teradata, which at the time I was the healthcare industry manager at the time. This was the real Cadillac of trying to do these things. One of our customers was a small health plan called Kaiser Permanente, who was very far ahead and very visionary, not just in implementing a comprehensive electronic health record system across all of its regions. And again, the state of the art in electronic health records was and still is a client-server application running on MUMPs. They were doubly visionary in that they said, just the operational system is great, but without an ability to analyze the data for that for lots and lots of reasons, not just the standard reports, but unconstrained reports, lots of different things, not just in one region or one instance of this client-server application, but across it. This is really vital to our business and our multi-billion-dollar, decade-long investment. They came to Teradata and said, how do you do this? Well, how we would do it today with Cloudera and Spark and this new ecosystem, and it's rapidly matured, is completely different than we probably would have done it then. Using the right tool for the job. One of the big challenges, one of the initial challenges was, so when they implemented all of these 8 instances or 9 instances of Epic data, electronic health record, they were all on different implementation versions. And so imagine the process of ETLing using, whatever ETL that Epic had developed, separate from the rest of the data warehouse world. This was the first real data warehouse for them. It required a giant Oracle server farm of just big iron just to mash that data. We wouldn't do that. We wouldn't do it that way today. Getting it into the data warehouse, there are all of these very complicated issues of when do you bring the data in and can we look back on it? Because for a simple question like, so how many patients did we have yesterday? Well, what time yesterday? And all of these type issues. This is all different. It required buying server farms in space for a health plan. Probably not their core business, right? Today we have the cloud. It's mature. And so it was amazing. And in fact, my senior architect on my team, a guy named Pratik Sandel, was explaining this all to me, and I was like, wow, where have I been? I was like, oh, I was in the government. And so I was a little bit embarrassed that I hadn't kept up with all of this, but at the same time, I was just amazed at what had happened and how this was very well suited, not to traditional claims data warehousing and this and that, but how it enabled these new data sets, streams of data from devices or web stream data and rapid analytics. And it got me thinking about, so how could we use this to solve real world problems for healthcare organizations and in life sciences? I mean, I just can't fathom trying to do genomic analysis using traditional relational databases. Just the cost of it alone would be painful.
Tell me, what do you think are the kinds of people that government needs, and what best practices as they're doing these new products, drinking their own champagne, and what are maybe some things to avoid?
So I'll give you a perfect, I did, when I moved to HRSA, I did in-processing. And it's great because whenever I'm walking the halls or at the cafe in the Park Lawn building, I see people with whom I in-process who are all over the agency. And there's a guy named Jacob Chang who in-processed with me. And we don't know what we're doing or who we are. And I meet this guy. And I said, Jacob, so what group are you in? He's like, I'm going to the CIO's office. I'm like, awesome. And I said, well, tell me about your background. He's like, I have a master's in computer science. I have a PhD in biology. And, I've been working at, this contractor for a long time. And we got to talking about, I'm coming from Intel and yada, yada. And I said, so what are you going to be working on? He said, SharePoint mostly. I appreciate that people see the humor in that, right? And so, just like my analyst, 3, yada, yada, who really is a data scientist, and that's what she does, and that's how she thinks, Jacob is thinking about more than SharePoint. He was very interested in the Internet of Things discussions. And so I would say as we hire, I really love working for the government. I mean, this is a calling because every single day as a taxpayer-funded person, you have to deliver something to the people and look for people who are into solving the world's problems, out there not scared to go address the challenges of the day. Look for people who want to work with other people and solve problems. And when you're hiring, maybe the USA Jobs rec doesn't say curious or interested or data scientist, but look for people who have those side skills. And like Jacob, who has a PhD in biology, right? What a great guy. And some of the discussions that we've had are, is the analytic capability for an agency or an organization an IT function or a business function or both? And that's a real challenge for agencies because, many times the contractors and others are sourced out of the CIO shop. But, how that data will be used, what data is needed there, the analytics, don't just leave that to the CIO shop. That there are people like Jacob who have that, background in both worlds, probably by happenstance, but thank God somebody hired a really smart guy. You can mitigate some of that, but that's my advice in finding folks. And keep people in government. Keep working. It's good stuff. Just be a positive force if you work in an agency and look out for the American people.
Thank you. I can't think of a better note to end on, and thank you everyone for your service to the government. So give yourselves a hand, give Matt a hand. Thanks.
Thanks for having me.